Countdown.
Yes. So we are starting in 3, 2, 1. Please start, sir. We are live.
Yes.
I would like to welcome Dr. Pratiksha as well as everyone to this wonderful meeting. Good evening, everyone, and a very warm welcome to today's CME. It is my pleasure to introduce our esteemed speaker, Dr. Pratiksha, senior consultant and vitreoretinal surgeon at Kiran Multi Super Specialty Hospital and Medical College, Surat. Dr. Pratik is an accomplished vitreoretinal specialist with extensive clinical experience and a strong academic and research background. He has completed his VR fellowship from the prestigious Sankar Netralaya, Chennai, and is a fellow of the International Council of Ophthalmology and holds the MRC ACD qualification. He has actively contributed to the ophthalmology fraternity through national and international presentations, publications, and faculty lectures at various platforms such as AIOC VRSI and international platforms such as URETINA. Today, he will be sharing his expertise on NAMD critical information for clinicians to enhance patient outcomes, which is a highly relevant topic in contemporary retinal practices. So, sir, we are delighted to have you with us. Over to you, sir.
Thank you, Yash. Thank you for the nice introduction. So, first and foremost, why we are discussing about the AMD. So, what is the prevalence? If we will look at the worldwide data, world current total population is around 800 crore plus. Out of that, at presently, around 19 crore people are suffering from age-related macular degeneration. So that's if we will look at the prevalence, that is almost around a 2% prevalence of the total population. And what we are talking about is a total population, not the targeted population. So if in general, we can say that if any random 100 people we are going to screen, out of those 100, any two people are there who might have this age-related macular degeneration. And this prevalence is definitely expected to go high and high by 2040, by another decade. So global burden of the age-related macular degeneration is a very, very significant burden. Now, what is the key thing about this? If for to know exactly symptoms associated with AMD, so word itself says a lot. It is an age-related. It is involved only the macula, and it is a degenerative disease. So basically, as it only involves the macula, your central vision is blurred. Patient will feel like a central scotoma. If they will try to focus on someone's face, they will see everything apart from the face. So basically, wherever there is a focus point, wherever there is a fovea and there is a macular area, that is the exactly area where this disease is getting involved. And because of that, the scotoma is there in that person. Now, apart from that, this disease may sometimes have a more severe form, like breakthrough vitreous hemorrhage, and in that case, general haziness of overall vision can be there. So basically, this age-related macular degeneration we divide into two variety, two entity. One is a dry age-related macular degeneration, and another is a wet age-related macular degeneration. Now, exactly what happens in a macular degeneration? In macular degeneration, there is a waste materials that getting accumulated in a form of drusen or drusen. Where exactly these get accumulated? This get accumulated initially between the Brooks membrane and RPE, and in advanced cases it may deposit even within the between the RP and the photos. So basically what actually happens, these multiple drusen, they are very tiny forms, and if they are very tiny, around less than 100 micron, they are known as early or small drusen. And when multiple drusen coalesces, they may sometimes come as a larger, bigger drusen. Like for example, this second image has just a few minor drusen which are like minor elevation in the RP. But if you will see here, multiple coalesced large drusen, and that is exactly acts as a cuticular or large drusen or intermediate age-related macular degeneration. This, what we are talking about, is the dry. Now, dry AMD advances and it can end up in a two. One, it can end up these multiple drusens coalesces and they damage overlying RP, and that will end up in a geographic atrophic area. Means overlying RP are damaged, they are permanently damaged. This area RP is not there, so those area becomes where you can easily see the choriocapillaries. Now, this can be the advanced variation of the dry AMD, but sometimes this can go end up in a more malignant condition, that is a wet AMD. What exactly it happens? Like when multiple this drusen accumulated between the Brooks and RP, they're not only going to damage the overlying RP, but they will also damage the underlying Brooks membrane. Now, this Brooks membrane will get a micro cracks because of the direct mechanical trauma, plus additional oxidative stress, plus because of the diffusion barrier, poor nutrition, poor nutrition to the Brooks. Now, that is exactly what happens, that microcracks in this Brooks membrane will end up in development of these choriocapillaries through this microcrack of the Brooks, and they may enter inside the retina. That is exactly what we used to say, that damage to the blood retinal barrier or outer blood retinal barrier. There are two blood retinal barriers. One is the inner and one is outer. When there is a damage to this outer blood retinal barrier, that is exactly where your dry AMD gets converted into the wet AMD. And this wet AMD, as we are discussing, this is a progressive disease. This may hamper the vision continuously. With every passing day, vision becomes lesser and lesser, and that exactly makes this disease much more important. Before few years, if I will say that, like in my early stage of the ophthalmology career, this is when wet AMD used to be there. We used to say that this disease is not treatable anymore. You are going to develop slowly, steadily lose the vision. Later on, like we used to treat it like to prevent the progression with the help of the thermal laser, TTT transpupillary thermotherapy. We used to ablate that area part of the retina macula, and we are going to create the permanent scotoma. But now, with the help of these recent advances, with development of these wonderful anti-VEGF molecules, we are able to treat this and this wet AMD. Now, exactly how this late wet AMD happens means, this is exactly what we used to say, that multiple drusen colysis, and they become the larger drusen. This larger drusen, because of the mechanical trauma, if you will see in the OCT, there is a significant damage to the underlying choriocapillary as well as the Brooks membrane and the overlying RP that crosses the progression of the choriocapillary inside the retina. And that exactly is the most aggressive form of the AMD that causes the rapid central vision loss. So basically, if we want to diagnose the AMD, it has a multiple aspect. If patient comes to you first, then that patient will have a reduced visual acuity significantly. So Snell's say you will come to know. If you are doing the AMSLR, then the patient will typically describe that central scotoma is there, or metamorphopsia will be there in early stage when scotoma is yet to develop. Then when you do the retinal examination clinically, we will find that okay, there is a blood, there is a elevation, and there are multiple clinical signs. Exudation can be there, and that is exactly where the retinal examination, clinical examination will guide us. After that, we can go with a ancillary testing. Ancillary testing most commonly utilized nowadays is OCT, as it is non-invasive. And with the advancement in a swept source OCT, we can see even up to deep choriocapillary and the choroid level. So definitely, even in case of the hemorrhages and blood, overlying blood and hemorrhages, that still we are able to penetrate, laser is able to penetrate and give the exact contour of the RP, and beneath the RP, hemorrhagic PED is there, or which type of the PED is there. In some cases, especially when OCT were not so great, to exactly delineate the sub-RPE level pathology, we used to use this indocyanine ICG angiography. And in between, when for the classical type 2 and type 3 CNVM, the angiography, FFF, fluorescent angiography is again useful. So basically, grossly, we divide this wet AMD into three parts. One was the sub-RP, that is a type 1, when it is still sub-RP. When it crosses the RP and enters in between the retina and RP, neurosensory retina and the RP, that is a type 2. And when it advances further and grow inside the retina, properly intraretinal development, that is a type 3. So type 3 is exactly what we call it as a RAP lesion. That's a retinal angiomatous proliferation. And these are basically the further classification of the AMD. Now, what exactly this AMD management is? It is more about how early you diagnose, because time lost is equivalent to the vision loss. Why? Because photoreceptor are non-regenerative cells. So once the photoreceptor are damaged, they are going to be damaged. The loss of the photoreceptor are always there. So there is only and only earlier you diagnose, better the vision you will able to give to the patient. Now, we already discussed about the pathogenesis and mechanism. So I will skip this further. And now, what exactly is available in our armamentarium? Which are the treatment modalities? So in the treatment modality, we are having a multiple anti-VEGF. Most of you are familiar with the ranibizumab. That's the most commonly utilized. But generally, we used to say that ranibizumab is something which comes in a one third, one third, one third. What exactly? Out of the total patients which we are going to treat, ranibizumab, with the ranibizumab, only one third patient will improve the vision. The remaining one third will maintain the same vision, and one third will still keep progression. So that is exactly was there is a drive for continuously better molecule. Then aflibercept came in role. After the aflibercept, still there was an unanswered question. So brolucizumab came, and presently we are having the faricimab as well. So what exactly are difference in between this molecule? Now, if you are looking at a binding affinity, so binding affinity is what is the lowest concentration of a drug that firmly inhibit the VEGF. So aflibercept has the lowest concentration that is required to block the 50% of the target. That's a VEGF, VEGF 165 to be more precise. If you look at the highest concentration is for the ranibizumab, and that exactly defines that why ranibizumab multiple injections, and in spite of the multiple injection, they still keep progressing because the drug binding affinity is much lesser. Now, or to achieve that equivalent amount of the effect of the aflibercept, that drug is almost, we can say that significant amount of the almost 200 times more concentration is required. And that is exactly second thing if we are looking at the molar dose concentration. So that is again lesser with a ranibizumab. Now, molar dose concentration is what exactly? In a total amount of this solution, what is the molar concentration of the monoclonal antibody? If you are looking at it, that exactly where the brolucizumab has a very high and more the molar concentration, that is exactly makes this why the high molar concentration is required in brolu, because it's a very small molecule. If you look here, it's the smallest molecule among all, and that makes it shorter in half-life, and that exactly makes the higher molar concentration of the drug when we are loading the drug. Now, which exactly targets these molecules are going to act on? So, if we are looking at a ranibizumab is a single target, that is just only VEGF-A. Now, if we are looking at a brolucizumab, it also is the same version, that's a VEGF-A. But if we are looking at a Eylea or aflibercept, that has multiple targets. It blocks the VEGF-A, it blocks the VEGF-B as well, and in addition to that, it blocks PIGF. What exactly it is? Placental growth factor. So this placental growth factor is one of the key driving force that actually regeneration of the vessels in the placenta like. So that is exactly how this choriocapillary also regenerates, and to block that chemokine is very, very important. That makes this drug much better. Now, if we are looking at newer, most advanced, that's a faricimab. That newer one, that is it in the same league? No, that blocks only VEGF-A. But we cannot compare it with aflibercept because it doesn't only act on VEGF-A, it acts on VEGF-A plus angiopoietin 2 as well. So that is a completely different way mechanism of action, right? Now, if we are looking at, okay, so what is the minimum concentration to have initiation of the action? So that lowest concentration, that's the potency of the drug, and best potency is with the aflibercept. Now, when we are going in a real world scenario, forget about the studies. See, there are two different things. One is when we study the drug in ideal situation, phase 1, phase 2, phase 3, and followed by phase 4. So that is in ideal situation. Why it is ideal situation? Say study, we recruit the patient, we treat them with a regular strict protocol. And most of the time during this study time, patient is not supposed to bear the cost of the drug. So once they are enrolled in one study, the patient is going to come regularly for that study, and according to the protocol of the study, patient is going to get the treatment. And most of the time, it is at the cost of the study's the sponsor. So practically, the RCT or any studies data may not exactly replicate in the real world, because in real world we are dealing with not only science. When we are discussing the studies, we are only dealing with the science. Commerce part is, though very important, is completely ignored. But if you are looking at the same thing, when we are looking at the real life data, then it involves significant amount of the commerce as well. So basically what exactly it means: first, number of the injection will matter. After giving the number of the injection, patient satisfaction in way of improvement of the vision matters. Even after the improvement, what again matters is the safety of the drug. Drug should not give the patient very unusual, especially in a current era, the intraocular inflammation or endophthalmitis, because it's an invasive procedure. So aflibercept is one of these. Why we are discussing this? Because it is one of the wonderful molecule which we know for more than a decade, for which there are in more than 6 crore of the doses has already been administered. And this is one of the drug which has proven very low intraocular inflammation rate. And that makes this drug as one of the important drug to be discussed. Now, are we only going, this may look like, okay, this probably is the probably company claims or whatever like that. But if what exactly science says that, forget about what the company says that kitne injections used and all, but what exactly science says that. To understand what the science says that, we take the study, and that is a randomized control study. That is one of the wonderful study, and that is known as Altair study. Why we are going to discuss only this Altair study? Because Altair study was conducted in Japan, and Japan is again the same Asian population through which we belong. So basically, that exactly we can project that data on ours. Second beautiful part of this study is, previously all the US studies or all the European studies that used to be fixed form study. Like every 4 week patient is supposed to come, they will inject. But that doesn't, and they will show that, okay, at the way at the 24 week, this is the vision, at 48 week, this is the vision, at 96 week, this is the vision. But that is not the real life practice. In real life, in my practice, each and every patient has a significant constraint, especially when recurrent treatment is there, price constraint, cost constraint, burden of the drug, so many things. So this study exactly address. Why? Because this study is not like every monthly injections. This study comes with that novel concept of the treat and extend. What exactly treat and extend means? This study has two randomized control arms. They didn't went to this blind follow-up of every weekly injection. They simply went with a treat and extend protocol. What exactly means that only 3 injections are given properly. That's 0 means today first injection in treatment naive patient, then week 4 another second injection, and week 8 that is another third injection. So here 3 loading injections we are giving to all both group of the patients. After that, we divide the patient into 2 groups. One is a 2 weekly treat and extend, and another is a 4 weekly treat and extend. What was the purpose? Because we don't want to inject every monthly blindly. We want to inject only when there is a required. So how we are going to deal? Like after 0, 4 and 8 injection, we are going to increase the gap by 2 weeks. Means, are we going to inject at 12 week? No. Either one arm will be getting the first injection at 14 week, another will get another first injection at 16 week. That is a 4 week treat and extend, and that is a 2 week treat and extend. Now, if we have injected at 14 week in one arm and at 16 week one arm, what exactly is going to happen in future? Now, after this injection, we are again increasing the follow-up by 2 more week or 4 more week, depending on the group. So what exactly happens is, like, if on the next follow-up, that is like after 14 week, that was a 6 week, now we are going to increase by another 2 week, that's 8 week now. So 22 week next follow-up will be there. Now at the 22 week, we are again going to do the OCT. Actually, every 4 week, we are going to follow the patient. In case in between there is a fluid or there is a recurrence of the fluid, then whatever the treatment free in the interval we have achieved, that we are going to reduce by same interval. Like if in a 2 week group, for example, after 8 week gap, 8 week treatment free interval, if there is a fluid, then this patient we are reducing the follow-up by 2 week. Means now we will again ask the patient to inject only after 6 week. If at the 6 week again there is a fluid, then we are again reducing that follow-up by another 2 week. Means again we will come back to 4 week. So we are going to 4 weekly injection only and only if it is damn necessary. If it is not damn necessary, if there is a dry retina, there is no fluid of intraretinal or subretinal fluid, then we are increasing the follow-up by further 2 week or 4 week. And what was the result of this study? That too not at 24 week, not at 48 or week or 52 week, at 96 week. That is in a practical real life almost 2 years. So at the end of the 2 years, in 2 week treat and extend and 4 week treat and extend, improvement in the visual acuity was almost identical. And average number of the injections, they were purely identical. Means even if we start the patient at 4 week treat and extend protocol, by and large at the 96 week, at the end of the 2 year, by and large, to maintain the same amount of the good vision, we need almost 10 injection. And what is the proportion of the patient who maintains 16-week interval? Means almost a 4-week gap continuously at the end of the treatment for almost 41% in 2-week group and 46% in 2-week group. So by and large, we can say that roughly 40 to 50% of the patient were in need of the injection once at 4 months with this drug, and that too in a disease which is purely age related. Means age factor is one of the key factor which is irreversible. And with this, how much we are able to manage the vision? So if we are looking at this graph, this is a wonderful graph in which every 4 week we have documented, means a properly documented vision is there. And if we are seeing that, by and large, initial improvement was better in a 2-week treat and extend protocol group. But overall, at the long term, both group has identical improvement in the vision. So that is the important take-home message, that this drug helps us in increasing the treatment interval and in reducing the injection burden on the patient. Now, if we are looking at UK study, means another data. So Moorfield UK data, what exactly it says? It is again saying the same identical at a long term 4 years. That what exactly it says that, see, 0, when patient is diagnosed with wet AMD, vision was 55 letters of ETDRS with the injections properly done at Q8. See, this is a 2Q8 means 2 milligram aflibercept at 8 weekly intervals. And that vision they have regained. So this is exactly what we used to say, that by European and UK studies was believing in a regular injections. So they were like every 4 week after loading, every 8 week they used to inject, and what the identical vision they could achieve almost at a 4 year. The initial gain of the vision at 1 year and almost at the end of the 4 year means the disease which is known to be progressive, known to be one of the directly damaging to the photoreceptor, in that disease also with this current improvement in this monoclonal antibodies is helping us in maintaining a very good vision for the significant amount of the patient for a longer duration, that is almost of the 4 year. Now, if we are looking at, see, we are dealing more about the Japan study, or because we are the Asian people. In Asian people, one variant of the wet AMD, that is a PC, polypoidal choroidal vasculopathy is very commonly seen. How much common? So almost we can say that out of the 100 weight or a PCV patient, around 22 to 60% of the patient are Asian, and lesser number of the Caucasian and Southern American part. So practically, we as an Asian having a very high burden of the PCV, and PCV is one of the notorious diseases. Why? Because PCV is a sub-RP disease, and when this is a sub-RPE, penetration is a significant amount of drug penetration will be lesser. The challenges will be definitely significant in treating this disease. And if we are looking at multiple different studies, if we'll see this CYTO study, that is a regular Q8 interval injection. Yamamoto study, that is a regular Q8 injection. Yamamoto, another study of 2017, which was dealing with a treat and extend. Hosokawa study, that was a purely treat and extend. Morimoto study, that was a treat and extend. Then another, the Morizane Hosokawa study, that was again treat and extend. And Morimoto secondary result, that was again a secondary result of the treat and extend. So this is a Morimoto 1-year result, and this was a 2-year result. With this drug, if we are looking at the ETDRS improvement, we are almost able to maintaining whether you follow the Q8 fixed interval or whether you proceed with a treat and extend study. For a longer duration, we are able to maintain good vision. And similarly, similar things are proven in other RCTs as well. That's View2 study, Vault study, Apollo study, and Planet study. The most recent Planet study is again saying that there is a significant amount of the good result. That's almost 10 ETDRS liter improvement in Q8 way of treatment with this drug, aflibercept monotherapy. Why we are repeatedly saying this aflibercept monotherapy? Because originally when this anti-VEGF used to came, that time we used to treat with aflibercept or any monoclonal antibody along with required as well as PDT, photodynamic therapy as well. So that is why we are saying that in a current era where photodynamic therapy is not easily available, dye is not very easily available, that is exactly when PDT has become a rare thing. This monoclonal antibody monotherapy is working equally well. Now, what is the safety thing which we want to discuss is, if all of us know that Rolosumab is one came with a big claim of the good molar concentration, so probably very good results, and Q12 to Q16 interval, but that drug immediately failed because of this significant amount of the intraocular inflammation. And as we initially discussed, that in real life, this thing matters a lot. Faricimab has definitely shown some cases of the intraocular inflammation, though it is relatively lesser with respect to the Brolu. But yes, it has came to in a light that retinal vasculitis was there with this faricimab as well. That recently came monoclonal antibody, where one arm is, if you will see this, one is green and one is purple. That is basically one arm is showing the VEGF blocking, and another arm is showing that angiopoietin 2 blocking. So that is exactly, and this is the aflibercept, and that is one of having a very good efficacy with very low rate of intraocular inflammation. That too over a long, almost we are using this drug for more than a decade. So that is exactly all about the wet AMD, pathogenesis, diagnostic thing, multiple studies, multiple monoclonal antibodies available, and its use, safety, and all those aspects. I'm very much happy to take any questions if you are having.
So we have Dr. Kalyani Bhatt here, Dr. Abhishek sir, Dr. Mahesh Singh sir, and we also have residents from various colleges. Sir, there are two questions in the chat box. One is, sir, how do you counsel your patient to take multiple injections, as one has to take the injection frequently and for a very long time? You are not audible, sir. Sir, I think you are not audible. Is it for me or for everyone?
Sorry, am I audible now?
Yeah, now you are audible, sir. Yes.
Yeah, sorry. So basically, first and foremost, don't show this matlab, very long term picture. First and foremost, I generally try to counsel my patient, okay, we will give the first injection, you see the improvement, and then we are going to discuss about the further path. If you will, from the beginning only, you will going to say that no, it's a long journey and multiple injections are required, minimum in a first year, this much injection, then patient will definitely feel significant amount of the pressure. And if you will first make the patient feel that what can be the possible improvement, if patient sense that improvement, then probably your life will be little easy on subsequent visit. Especially there might be the kind time that patient may lose the follow-up in between, and but once by and large they will see again the improvement, re-injection, then definitely your life will be little more easy.
Okay,
Yeah,
sir.
I agree with what has been mentioned that yes, Visudyne has wonderful.
I think there is some.
Visudyne is
Yeah.
reintroduced in India by Orolab. So originally Visudyne was supplied by Novartis. Novartis discontinued for a long time, for almost 3 years. We didn't had a Visudyne. Because of that, PDT was almost getting obsolete. Many hospitals had a PDT machine. That laser machine was there, light source was there, but just because lack of the availability of the Visudyne itself, that's the photo dye which was used. We were not able to, but very recently Orolab has come out with that, so that can be one of the again a treatment option.
Okay, Dr. Kalyani has raised her hand. Ma'am,
Okay, yeah, please. Hello, Dr. Kalyani.
Hello, Dr. Pratik. I just had one question that
Yeah, please.
when you said about counseling the patient related to number of injections and the length of the treatment, what
Yeah.
happens sometimes clinically when what I face is that say for an example after one or two injection patient is not getting. Am I audible?
Yes, yes, you are audible.
Yeah, if the patient is not getting a response, then
Yeah.
they may
So
lose patience, and
they
then
may lose trust as well as the patient.
uh,
So what exactly here important thing is a proper case selection is very very important. You had raised very right question in a way कि because this disease is more involving the central vision. Many times what happens that we come across this patient at very late stage or advanced stage where we may not able to regain the vision in a very good way.
and
So
then
those,
they feel that my doctor is not treating me properly,
yeah,
maybe, or
yeah, very,
they
no, no,
may seek for
absolutely right.
a second opinion, and then if
Yes.
they get an improvement with another injection, then they feel that okay, this
Yeah,
was
yeah,
the thing.
yeah, that is
So
a very true real life scenario, and that is exactly where the proper case selection and unfortunate part in a certain like most of the many times in our clinic that do happen that patient we do get present other eye is a good having a patient is having a good vision in other eye, so that because of that as well patient sometimes may not be aware that this eye has started disease. Many times patient feels that it is because of the cataract only and they get operated for the cataract, and post cataract also then they came to know that there is a wet AMD sitting behind. So there are so many, these are the challenges which makes the later or late presentation of the patients. And because of that, as I said that this in this disease that early diagnosis is one of the key. At the other hand, if I will say that yes, you are very much right in raising that point. But at the other hand, if I will say that I have many patients in which if early diagnosis, the patient presented early and we would have maintained the still good vision. So very rightly, it's one of the little debatable area. But at certain feel, I always feel that if some patients we may lose, and many patients we may able to retain, and it's just a journey. That's all.
Thank you so much, sir. There is one more question in
I
the chat
think
box.
rather than it's a question, it's a comment from the Abhishek that yeah, he feels that ki probably a package or he would like to prefer. Yeah, that's can be a personal preference that if he wants to explain the patient about the possible longer package than just one injection or three injection at a time, that if that works with a good in his hand, then I think that's a wonderful thing. But that can be a one of the way. Many patients, even I even sometimes try to explain, especially when ILIA for you was there. So I used to explain that patient, initially 3 to 5 injections to lagna hai and this scheme might help you. So that can be a way to go, definitely.
Certainly, sir. And there is one more question, sir. In real world practice, how durable is the effect of ILIA in your AMD patients?
So yeah, that is again little tricky question in a way because each and every patient may not present at the same level. Second thing, we may not always get the treatment naive patient that we used to study and discuss. In the studies, most of the time they select always treatment naive patient. So we are never ever going to get the treatment or very like limited number of the treatment naive patients we used to get. And many times later presentation that will again make the little limitation, but by and large in my practice I generally try to follow it in a way ki slowly and steadily I reduce the burden, I try to increase the gap. But most of the time in our real practice we try to follow PRN, like we inject the patient and try to keep the patient with a home answer chart monitoring, or if patient is very educated ready to come for the regular follow-up, then we, but exactly the study protocol may not able to fit in a real life situation, and that is exactly the reason that we may not exactly able ki how many percentage of the patient we will able to achieve the Q16.
Okay. Right, sir. So if there is any other questions, Abhishek sir, Dr. Mahesh Singh is here. He has recently joined ASG Surat. So
Oh, wonderful.
yeah. So in last month only he has joined. He came to Surat and joined ASG, sir.
Okay, hello Mahesh, how are you? I think he's mute.
Hello. Good evening.
Yeah.
Good evening, doctor. Lovely
Good
to be
evening.
here. Very valid points made. A lot of insightful talks, and I am very happy and glad to be here. Just to add a few things that Dr. Pratik just pointed out. Somebody asked the question of the durability of ILIA or aflibercept molecule per se. So durability is something that you cannot say right from the beginning, but if you go by the studies and everything, the effect is known to last for 6 to 8 weeks. So if that is the question that needs answer, I guess you can see the effect of your drug for lasting for about roughly 6 weeks. So you don't have any hurry, or you can tell the patient to just relax and see the outcomes, and then we judge about the next injection. We can't promise that you will require 2, 3, 4, 6 because there is no machine to assess that.
Yeah, so that is exactly we generally follow it's purely a PRN
Yes.
as and when required.
Yes, that's what I also do in my practice. We usually go by PRN, and as ILIA for You was a beautiful program that gave a good shield to patients who were needing those naive patients who we knew will require 2 to 3 injection to begin with.
Absolutely.
Dr.
Yes,
Pratik, just one question I wanted to
Yeah,
pose
please.
from my end was,
Yeah.
in your practice, when you see a naive patient who has a advanced disease, what is your choice of drug? How is it the patient paying capacity that dictates, or is it the standard thing that you go by, aflibercept, faricimab, and the ranibizumab? What do you make your decision on, or is
So
it purely commercial which takes right?
yeah, that's a very valid question, and I would appreciate to share my real insight. So I generally look at a patient's profile. If I feel that this patient is willing to take a little burden, then I will directly give him choice of the aflibercept, preferably for wet AMD specifically. I will directly go with a ILIA, means aflibercept or any molecule above that. I generally try, if patient is having a good profile, I won't even nowadays I don't give the ranibizumab option as such. But if I feel that, I personally believe that कि अपने यहाँ एक कहावत है गुजराती में खास करके, नहीं मामा करता काणो मामू साहब. So rather than no treatment, some treatment is always better. So if I feel that patient is absolutely not able to afford, or this patient may like not able to manage or come, then at least I will try to give them ranibizumab. I don't use bevacizumab, Avastin in my practice, so I have only these few limited options.
That's a very valid and real life answer, doctor. Thank you so much.
Yeah, nice meeting you.
Same here, sir.
Any
Dr.
other question?
Abhishek has a comment. How many of us retina surgeons believing in injecting in a totally scarred macula with intraretinal cystic spaces, probably CF vision?
Yeah, so I think this is a question for almost all of us who are there. And I think Dr. Kalyan is also there. And Krish Bhavsar, is it Dr. Kaushal Bhavsar, sir?
I don't think so, sir.
Okay, fine. So yeah, we can start with Abhishek Kalyani, and then I think I can Mahesh, and I think Dr. Saurabh is also there. So
So just like to add something. So
yeah.
in my practice, when we have seen CNVM cases,
Yes.
many of the patients come with a scarred macula in one eye patient status.
Yeah.
They just come to us saying that I have gone to every clinic, I have been injected multiple times, but I don't know whether there is any latest advancements in treatment where we can get a surgical treatment option or something. So
Right.
in those cases, when I have told them, I understand that you have taken treatments, but those were all haywire treatments, as in they have never completed 3 doses, or they have never,
Very true. Very
followed to
true.
the PRN regime or TREX regime or anything. So in such cases, when I had told them, see, I will give you a trial provided you stick to the protocol.
Right.
If there is an improvement, we continue it. If there is no improvement, we stop after one injection. So I
Correct.
started with first injection. Believe me or not, they always see some visual improvement and morphological changes, that they are able
Right.
to identify faces. They are the structure of the objects that you're seeing is much better, and they maintain it till they take injections. As soon as they go off treatment, again they have the same black scarred vision on the Amsler's grid and everything. So I don't know how useful these injections are for those patients, but I feel these injections still make a difference till the time you don't have any alternative surgical option.
Right. So basically, in my practice, also generally, see if patient is not feeling symptomatically improvement, then definitely all of us are going to the discontinue it. And yeah, it is one of those diseases that where intraretinal cystic fluid, if that reduces, that definitely reduce the metamorphopsia. But at the same time, we are not going to treat the anatomy or OCT, and we want more like a classical thing of the as matlab, patient's thing as well. So if I'm looking at purely scar macula, I will be little reluctant, very honestly speaking. Yeah, because practically I try to explain them proper guarded visual prognosis. If after that they are motivated, I will definitely inject. But proper, if that is a scarred macula, that is what I will try to follow. Yeah, Dr.
Agreed, Dr.
Kalyan.
Pratik.
Will you
I would like to actually look at the duration of the symptoms and how many injections
Yes,
or treatment
rightly
they have
pointed out.
taken before. If it is a long duration scar, then there are very less chances that IRF will go down with the injection. If it
Right.
is like ki, they are already on the treatment, but they are not seeing any treatment improvement in the vision, and that's why they are coming to me, then I can tell them that I can try. And if IRF is reducing, or if you are feeling any symptomatic improvement, we
Yes.
will continue. So I had few patients that actually came up with scarred CNVM and hemorrhage in it, like literally gone eye. But they stick to me and they take multiple Avastins, and now hemorrhage and everything has resolved, and scotoma size is also reduced. So
That's wonderful.
the patient is very happy because that was the seeing eye, because other eye was scarred already. So that depends on the patient profile completely.
Very true. Very true.
Lovely,
So I
lovely
have
outcome.
treated those kind of patients who are actually having a lot large, like CNVM and
Correct.
hemorrhage on it, and they actually respond with the treatment, multiple Avastin and everything. But typically, it will decided by the OCT and the activity at the visit per se.
Right.
Uh, I would like to go by what Dr. Pratik just said. Also, you see the other eye as well. So
Yes.
treat both the
True.
eyes at once. You see the other eye. What is the status of the other eye? If you have a scarred macula in one eye and the other eye is doing well, there is not so much of CNVM or no CNVM at all. Don't try to inject this eye which has a macular scar. This is not going to help because you yourself have noted the chronicity that multiple injection has been already tried. So that cystic spaces are something which are very chronic, and there is something what we call in our practice allowable fluid. How much fluid are you going to allow?
Yeah.
So
Is the dry is the real dry? Very
yeah,
rightly pointed out.
yes, correct, doctor. So you see all those factors and then you make a choice. Does every scar warrant an injection? Any fluid that you see on the OCT requires injection or it does not require? So as doctor also mentioned that she sees that how long has the disease been sitting on. So
Very
you
true.
see all those factors, you take 4 or 5 factors into consideration before you decide that you want to touch that eye and want to give any injection, because even the what do you call cheapest injection will cost you around 10-12,000 in a private setup.
So
Absolutely.
So you don't.
first of all, if it is a scarred macula, there is no point of
There is no
injecting.
point. Agreed.
Absolutely.
Yes,
Agreed.
that
That
is
that
that is for sure that you have to decide whether the disease is active or it is inactive. If it is scarred macula, then there is no point of injecting.
agreed, doctor. Scarred macula with an active disease with hemorrhage surrounding it, I would still not inject because it is not going to benefit the patient. There is no
Yeah,
visual
and
outcome that
there
he
you
will be
have to
judging.
take a call. Yes, yes, there you
Agreed.
have to take a
So
call. That
treating even in.
how the sometimes even the size of scotoma reduces. So sometimes like one-eyed patient,
If that
you
is the
need to
only
take a
one-eyed
call.
patient, I would like to try and give it a like last ditch effort, but not in the patient who has the other eye, which is functional or has less edema. So I guess I agree with you.
It was a very nice discussion, Dr. Pratik, and really informative session.
Yeah, thank you, Dr. Kalyani, for bringing out also very important point. Thank you, Abhishek and Mahesh, to make it really live, interactive, and active. We would like to even any PGs. I think few PGs has also joined, so I will suggest them not to hesitate. If you have any silly questions, feel free. You are having a panel of the very good retina surgeons, and you will definitely get a good answers.
So the floor is open. If anyone have any question, like
Yeah.
they can ask.
And if everyone is fine, fully satisfied with what the put they had with in terms of the knowledge, then we can even close the session as well.
Sure, sir. And sir, as Dr. Abhishek just put in the comment that he has some cases of Eylea injection. So, like in next meeting, we can have rather than this clinical and company made presentation, we can have case based discussion as well in the
Wonderful.
next meetings.
That is even, yeah, that will actually give us the more real life scenario.
True, sir. Okay, sir. So I think, yeah, it will definitely be more interactive than the current one. Yeah, sure. Okay, so it was really a wonderful presentation, Dr. Pratik, and thank you so much everyone for the active participation as well as the discussion. Thank you so much, everyone. Good night.
Thank you. Good night.
Tech team, we are good to close.
We are offline, sir.